is Theron Stinar. I'm a family physician at the Fredericksburg Christian Health Center. And just to give a little bit of background, the Fredericksburg Christian Health Center, we're in Fredericksburg, Virginia. It's a small town in between DC and Richmond, and we're a small clinic. So I'm curious who in the audience is also from a small organization. So, oh, that's awesome. Most of you guys, that's great. I feel like a lot of years and often a lot of the presentations, especially like from the big stage downstairs, we're hearing from people from Lawndale and Esperanza and some of these bigger organizations. But there's a lot of small guys too, and in some ways, some of the issues can be apples and oranges. We don't have the same resources. And so we're a small clinic. We have about 20 staff and regular volunteers. We're a family practice clinic. We're not an FQHC. We're a free and charitable clinic. We're actually kind of what's called a mixed model clinic, if you're not familiar with that. So half of our services are charity care for Medicaid and uninsured patients, and the other half of the services are for people with private insurance and Medicare. Although many, if not most of our Medicare patients are also dual eligible for Medicaid or are on Medicare disability or otherwise fixed incomes and living in poverty. So that's kind of who we are and who I am.
I'm Teresa Bowers. I'm the Health Innovation Navigator at Micah Ecumenical Ministries, and we are a nonprofit organization that provides services to our homeless population in Fredericksburg. We were founded by 9 local churches in the community. We call a person experiencing homelessness a neighbor, so you'll hear me refer to our neighbors this afternoon. And we have a number of services, but particularly our hospitality center, which focuses on providing basic needs to those folks that are living on the street. And we also have an extensive housing ministry where we house a little over 100 people. So that's just a little bit about who we are in Fredericksburg.
Before we kind of get into the nuts and bolts of the presentation, so we're going to be talking about a program that we have called Health Bridge, which is a Fredericksburg Christian Health Center partnering with other ministries, Micah being the first one that we partnered with in this way, where we provide healthcare services outside of our clinic at their locations. And we're going to kind of get into some nuts and bolts of how you can do similar types of partnerships and what that looks like. But I do want to give you guys a little bit of a context of how this idea of Health Bridge and these community collaborations came about. So Fredericksburg Christian Health Center, we're on our 23rd year of ministry right now. So we've been around for a little while. And primarily our services have been to the uninsured. Micah Ministries you guys are 20 years now, right? So they're on 20 years. And so for a couple of decades, we've partnered together, but it was more just referring people back and forth to one another. And especially because most of the uninsured or most of the unhoused neighbors were uninsured. In 2019, Virginia expanded Medicaid. And so suddenly most of our uninsured patients now had insurance. And so that kind of got the leadership in our organization thinking about, all right, our service demographic is changing. Who are those that are in the most need, kind of the least of these in our community now, and do we need to kind of change the way we're doing things to meet those needs? And at that time, we were thinking, okay, those who still are uninsured or having difficulty accessing the system are those who are unhoused or immigrants and refugees. And that was kind of the primary demographics that we were thinking about. And that was 2019. So then 2020 hits, right? And there's other problems that come with that. But one of the things that we really learned in the pandemic too is that there's all these other social determinants of health that are really driving things. And the pandemic, I think, really opened the medical community's eyes up to ways that we have been letting things slip through the cracks and letting people slip through the cracks. And so during those years, it was really formulating the ideas for a strategic plan that we started implementing last year to start providing healthcare services in non-traditional ways to meet those who are in the most need in our community that aren't getting services. Around that same time period, the same thoughts were going through the heads of the leadership at Micah Ministries. So they had, been around for close to 20 years at that point, 15 years. And they were seeing that as they were doing such a great job getting people into housing, helping people maybe get some job training or kind of get out of the survival mode of living on the streets, that there was new problems coming up in these people's lives. And most of them were healthcare related. And also realizing that most of a lot of the core things that were keeping people on the streets were due to unmet healthcare needs. And whether it was untreated mental health or someone just has horrible diabetes and they're getting wounds over and over and they're in and out of the ER and they can't hold a job, and just seeing that there's all these needs that this community needed that had more advanced healthcare needs, and that couldn't just be addressed with trying to tell people to come to our clinic, because it just wasn't going to be addressed in that way. And so I started having conversations with Megan Cotter, the CEO at Micah Ministries, and we kind of had this idea of what if we came to you and provided health services for you. So about 3 years ago, they hired Teresa and we said, let's make this happen. And so we started providing services at Micah. And then a year later, we started doing it with another organization called Empower House, who takes care of women that are victims of domestic violence and provides safe houses and wraparound services for those women. And we're expanding the program to other ministries also. So that all being said, did you want to add anything to that? Okay.
Okay, so we're going to just quickly go over the course objectives just so we can help stay on track. We're going to collaborate with other organizations to creatively overcome barriers that lead to unmet health needs, assess what are the needs in your community. We'll identify potential ministry partners who are also addressing the greatest community needs. We'll create shared healthcare objectives based on client needs and organizational priorities and limitations. We're going to think outside the box to how you can bring health services to those in need through your ministry partners. We'll develop a MOU clarifying roles, logistics, personnel, and funding. Bear fruit as two branches connected to the same vine.
And as we're going through this, certainly feel free to raise your hand if you have a question, and we'll try to answer it. More sensitive questions, we're going to try to have a good 10 minutes or so at the end to really kind of answer some of the, all right, exactly how did you do that type of questions, just depending on how we're doing our timing. If you have something, raise your hand and we'll try to address it if we can. Otherwise, we'll wait to the end. So if your purpose of collaborating with another organization is to better meet the needs in your community, the first thing that you need to know is, what are the needs? What is actually going on in my community that my healthcare ministry can step into and step alongside someone else to meet those needs. And one of the best ways I would say that you can identify what those needs are is by doing a community health assessment. So certainly you can interview your own patients and say, hey, what are your needs, or what are the needs in your community? Where are people having some healthcare needs that are still not getting met despite what we're trying to do for you? But you can also perhaps avoid reinventing the wheel by tapping into a health department community health assessment. So most of your health departments, especially ones that have certain levels of certifications, are required to do this every 3 years. And all of your nonprofit hospitals are required to do this as well. So if you have a nonprofit hospital in your community, they're already doing this too. And essentially what it is those organizations will do mass interviews and surveys throughout the community, and they'll meet with a variety of community leaders, not just in healthcare, but in all services provided in the community. And then they'll also have kind of a select group that's kind of the steering committee for this whole process. And through all these interviews and surveys and data analysis, they determine what are the top 3 needs in our community that we are going to kind of put all of our resources and funding together to try to meet these needs. And they'll come up with what's called a community health improvement plan. And that plan will have all these different objectives of how are we going to meet those needs over these next few years. I would encourage you to make friends with your health department, because you could be asked to sit on that steering committee and have a seat at the table and give your input based on what you see your patients experiencing and what they're telling you. Hey, these are things that we really should have in our community health assessment. You can advocate for maybe your clinic's programs to be a part of that community health improvement plan. in which case there's an obligation from the local funders to support that program. So, of course, you're not just doing this for the money. You want to meet those needs, but there's a lot of benefits to being involved in this type of process. So, for decades in our community, of the top 3 needs, every single time, access to healthcare was always number one. Always number one is we have people that are uninsured, or we have people that are just not getting the services they need. We need more safety net clinics or funding to safety net clinics or whatever. And so that was great for us as a safety net clinic. 2022, something really unique happened. And over all those years, you'd have access to health is number one. Number two would usually, 2 and 3 would usually be something like chronic disease management, obesity, cardiovascular health, things like that. That's usually what we would see for some of the other things, maybe education, mental health, substance use. In 2022, our community identified that the number one healthcare need, the number one thing that was preventing people from having high quality health in our community, was safe and affordable housing. It had never been on the list before, but now this was the thing. And either because people were living in unsafe conditions or on the streets, or because the cost of housing was so high in our area that people could not afford to get their healthcare needs met because they were just trying to get their shelter needs met. So that was really interesting. Number 2 is mental health, and 3 was access to care. So we still made the list, the primary thing, that we tend to take care of in our healthcare ministry is access to care. And we do have some integrated behavioral health also in recent years. But this was really interesting, and it really and we were already in the process of having these conversations about this Health Bridge program, but it really demonstrated yes, this is what our community needs. And actually, we're going through this again now, this year in 5. And it's those same 3 again. It looks like mental health might outdo housing, but it's still, those are going to be the top 2, and access looks like it's going to be number 3. So those are things you think about. The social determinants of health also, things that, are kind of, maybe they weren't in the top 3, but that tend to be high on the list. Things like food insecurity, transportation, substance use. There's so many things that could be on there.
So we're going to give you a chance to get awake if you're having trouble with that after lunch. We're going to have a little audience participation here. So if you will turn to the person sitting next to you or the person right behind you, if there's not anybody real close, just jot it down on a piece of paper in front of you. Take just about a minute to answer this question. What would you say are the top 3 unmet healthcare needs in your community? So share that with each other for just about a minute. Okay, let's come back together. This was just a brief exercise. How many of you identified one of those 3 that we just identified? Just show of hands. Okay, so some of that going on in your communities. Just to shout out how many, or what were some of the other top things that you identified with that were not one of the 3 that we've already mentioned?
Okay, so now that you've identified, or you're getting an idea, hopefully juices are flowing, what the needs are in your community, kind of the next step is, all right, who are you going to partner with, right? Who is already meeting some of those needs, or because our organizations, our mission is healthcare, right? That's what we do. Whose mission is to address maybe that other thing that does have some healthcare tie-in, but that's their mission, and they're doing that. And so who are the people that you can come alongside of? And we'll do that exercise again in just a minute. I'm going to share with you some of the organizations that we partner with. And believe it or not, this is not completely exhaustive, but just to kind of give you some ideas of maybe who you could partner with, or the types of organizations that maybe that you wouldn't have even thought of. So we talked about housing was number 1 for us. So we have Micah Ministries. They are not a shelter, but they provide a ton of services for those who are unhoused. In our community, we do have a shelter called the Brisbane Center. So that's an organization that we could come to and provide on-site service at the Brisbane Center. Another organization is called Mary Shelter. They provide housing for women who are pregnant that are unhoused, which is huge. A lot of these women have become unhoused because they got pregnant, and they actually will provide up to 3 years of housing. So through the whole pregnancy, support for the mom and baby, parenting classes, job classes. So, really, really awesome. I have several homes with several families in each home. So those are some housing ones. We also have an organization called the 516 Project. So this is a Christian nonprofit organization that does home repairs for those living in poverty. And you might think, okay, how can we partner with them? Certainly we can refer people to them and vice versa. We do a staff retreat every year. Each year we try to do some sort of fun activity or, team building activity for our staff. Last year at our staff retreat, we spent the afternoon with the 516 Project doing a home remodeling project. It's just kind of a cool thing that we could do to help out with them. A unique thing that you might not think about. For mental health services, we are so fortunate in our community. We have 2 Christian organizations that provide services for those who are struggling with substance use. So there's an organization called Beauty for Ashes that has 2 homes that are residential treatment centers, 18-month program for women that struggle with substance use. And they are there on site. They pretty much don't leave except maybe to come to a doctor's appointment. And so when they do, their staff has to come with them. And so for us to go to them is a huge relief of burden on that organization. Zoe Freedom Center, their focus is a little different, mostly on like harm reduction, CSAT counseling, peer support counseling, things along those lines. They're in the process of building a residential center also. But we have those 2 organizations. We have Empower House, who I mentioned, who, although it's not kind of strictly mental health, they're caring for people who are victims of domestic violence, right? There's some significant mental health needs that are there. For nutrition, for example, we partner with the food bank, which I'll talk about later. There's an organization called the Virginia Community Food Connections, which is a nonprofit that gets food from local farmers. We kind of have 1 foot in DC suburbs and 1 foot in the Virginia country. And so we kind of have a little bit of both feels, but there's certainly that rural population that we take care of, which is another community in itself that needs help. But we have Virginia Community Food Connections in the food bank. We have nutritionists that partner with us for food insecurity needs. And so those are kind of some of the ones that we partner with. 107 Farms is another one that does some food. They actually do a lot of peer support counseling, community health workers, things like that can help us from a mental health standpoint also.
So let's take a chance to do another audience participation. So if you would turn to the person next to you or a person behind you and name at least 2 partners or potential organizations that your clinic could partner with to meet health needs of the least of these in your community. Let's take about 2 minutes to do that. Okay, let's come back together again. How many of you and your partner were able to identify at least one organization that you could potentially partner with? Okay, great. So now we're going to go from identifying the needs to identifying potential partners or possible partners to how do we formalize partnerships? What's next? So let's begin to consider some things in formalizing a partnership with someone. So the first thing we want you to think about is what healthcare goals does a potential partner have for their clients? And what do they wish you could do for them? So 3 years ago, at about the same time that Dr. Steiner's practice began to focus more into moving into the community healthcare, I was hired by Micah to start a formal healthcare ministry. At the time, we already had an 8-bed residential respite care, but we didn't have any other health care for the rest of our neighbors, the 250 that were coming into our hospitality center every month and the 100 plus that we were serving in our home ministry. So before we could identify our goals, I began by looking at what did we already know about our neighbors and their needs. And most of this information came from our existing staff. When I came on board, I kind of polled everybody, and actually they told me, we'd like to do this, we'd like to do this, we'd like to do this. So I came up with some things from that early time. And so the things that we already knew were that our homeless neighbors were using the ED to address their primary care, as well as their urgent and emergency care. Most of our neighbors that were living on the street didn't have a primary care provider, and they didn't know how to find one. We knew that there were many barriers to getting their health care, including transportation needs, how to make an appointment. There was an article in 2020 in Health and Social Care in the Community that reported that while the unhoused have a high utilization of the ER, this does not significantly improve or prolong their health. Cited in the article, they cited these reasons that the unhoused don't seek primary care. They're living in survival mode. They have a general distrust or fear of primary care and the healthcare system, and they have a social discomfort in formal office settings. Imagine being dirty, smelly, and trying to push your shopping cart full of your personal belongings into a formal office. It just wasn't something that our neighbors were doing. We knew that our unhoused neighbors didn't have any formal support to establish primary care, and they often used the ED for this reason. Our neighbors were in poor health, often with multiple untreated physical and mental health issues. We also knew that as they became housed, often with us, that they wanted to age in place, just like the rest of us, but they were getting sicker, and this brought up the issue that those previously unattended health issues were causing more problems in terms of home and ADL safety for us, and that was resulting in more APS referrals. So we prioritized this information of what we already knew about what our neighbors were obtaining as far as healthcare or not obtaining, and we formed some goals. So our main goal was to begin to intentionally identify those needs, goals, and then begin to specifically address them. So our goals were, 1, to address disease prevention by providing health screenings to our street neighbors, 2, to provide basic health education and resources, and 3, to begin to provide primary care at our location. And at that point, we knew we needed partners to help us. We couldn't do that by ourselves. So we began to identify potential partners, and our partnership with Dr. Stinar's clinic was formed when he reached out to us at about that same time to form a collaborative partnership. So specifically, we asked him to do the following. We wanted him to offer primary care to our neighbors that did not have access by bringing it to them into our spaces. We wanted to help our neighbors decrease the utilization of the ER for their primary care. We wanted to help with documentation for our neighbors that were working toward disability. We needed some documentation of disability, primarily diagnoses. And then we wanted to assist with capability assessments for permanent long-term placement for some of our senior neighbors. So over time, as our needs grew, new goals were formed, and we have continued to expand this ministry. We sought out other healthcare partners, and we sought out other non-healthcare partners. Most recently, I met on Tuesday with our downtown library about partnering with our health screening program. So that's just an example of a non-healthcare partner that I just met with them on Tuesday. So I reached out to all the connections that I had in having been a healthcare provider in the community for a very long time. And then I reached out to our staff, our board, the 9 churches that were our forming organization, and began to ask for things that I needed. I told the board when I was presenting about progress that I needed a nurse. I reached out to another physician that had worked with Micah years ago. So I started reaching out to everybody that we could. The next thing that we needed to do was consider the types of services that our specific population needed. So what are those needs that you've identified that you want to try to address? As Dr. Stinar has already talked about, for example, at Micah, through this process, we identified the need for the following services: health screenings for general wellness, which we do with 2 community colleges, partnering with 2 community colleges. We needed primary care, which we now partner with 2 physicians from Dr. Stinar's practice. We needed behavioral health treatment, counseling, group therapies, skills training, and psychiatrists, and we partner with 3 behavioral health partners at this point. We needed dental care. We partner with 2 dental practices in town now. We needed vision care. We partner with the Lions Club, and we needed health education and community resources and referrals for special healthcare needs, specialty healthcare. Then we looked at our capability. Consider what were the staff needs that we would need in order to do some of these partnerships. What were the material needs that we identified? And what funds do we have available? So when we consider the staff needs, how will you staff this partnership to meet the services that you plan to offer? How many hours can you devote to this partnership? Will it take away hours from another program? Or can you fill this need with a volunteer? For example, one of the 2 physicians that serves us is a volunteer, and she was assigned to the MICA Primary Care Project as a volunteer. We use both paid staff and volunteers for our partnerships, but note that even great volunteers need supervision and oversight. Let's think about the material resources, just to name a few, to run the program that you want to offer. These include considering your space. Is there a designated space for this program, or do you have to share with something else? And at MICA, we have to share. So we have a clothing closet, and on Thursdays, we close our hospitality center, and we push everything back in our clothing closet, and we put out an exam table that Dr. Steiner's office has loaned us, and that's our clinic space. So it's a shared space. Consider the privacy of the space. The reason I say this is that the clothing closet that we use for our primary care clinic doesn't have a door. So that's one of the reasons we closed the clinic that day, is so that we could provide some privacy to our patients. What equipment will you need? Do you have computers to document care? Is there a software program to use for documentation? Again, I mentioned our portable exam table. We also have a file cabinet to store basic supplies and equipment. So consider these things when you begin to think about the material resources that you're going to need. Then there's the funding for this partnership. What limited resources are available? Do you have any budgeted funds? Do you have funds from supporters or grants, local, state, federal grants? Are the grants one-year grants? Are they recurring? We've been very fortunate to be working on a recurring grant. Is anyone doing any fundraising or capital campaigns for this program that you want to partnership on? Or are you billing? For example, in our partnership, Medicare can be billed only if the patient is seen in their residence, and it varies from state to state whether Medicaid would cover primary care outside of a clinic setting. Or perhaps you have a mobile clinic that you can bill to if it's considered a designated point of service. So these are all things to consider when you think about the capabilities of your program. Next, how you go about delineating responsibilities with your partnership. Considering all of the responsibilities that you identify into an MOU between you and the partner organization. Consider the coordination of care. Who makes the appointments for your patients? Or is it first come, first serve? Who reminds them of the appointment? You know, that little reminder that you get a text, you get a phone call, you get an email. Many of our neighbors don't have a phone, or they don't have a working phone. It got lost, it got stolen, it got broken. How will your patients get to you? What transportation needs will there be? Is that going to be an issue? That's one of the reasons we brought our healthcare into our hospitality center. What about treatment adherence? That's a huge issue for our homeless population. And what do you do about no-shows? What about follow-up on care needs? Who will do the follow-up? For example, if your physician orders an x-ray or lab work, how do you assure that that patient's going to get that lab work or get to that x-ray? You may have to help arrange that for them. For our population, they're not going to likely do that on their own. So that's where our robust case management system comes into play. Someone might have to, so to speak, get them by the hand and take them to take care of those kinds of things. Next, consider documentation and record keeping. Who does this? What do you document? Who buys the computers? Is there a particular software that you want to use? Are there any forms that you might need to use in this program? Who's going to develop the forms? What about tracking data? Lots of people may ask you for data on your programs. Everybody's going to ask you for data. Lots of people might wonder about who's gathering that data, who's keeping track of the data, who needs the data. Is the data required for a particular grant report or to justify a grant? Does your board ask you for data? How about your stakeholders? Then consider what the specific roles of the staff will be, or the volunteers that might be providing the services in this partnership. They could be direct care providers, they could be administrators, they could be an office assistant, or they could be a greeter. For example, we have a greeter on Thursday mornings because our hospitality center is closed and our clothing closet is in the back of our building. So we have a greeter that is there to open the door for those appointments, for those neighbors that come for their appointment. That greeter helps us fill out the HIPAA form, get their current insurance card if they have one. So consider the roles of your volunteers and staff. And then lastly, what about financial support beyond the capacity we've already mentioned? Who's going to be the grant writer? Is the grant shared among several partners? I mentioned that Dr. Stinar and I both are paid out of the same grant. It was an innovation grant, and that's why that's part of my title. And so part of the reason we received the grant was that it was an innovative partnership. And I will say that when you're doing fundraising, you have to maybe have some designated staff or someone designated to help with the fundraising piece. Do you have different reimbursement models? Perhaps you're doing some billing. Maybe you're doing pro bono services or charity care. So these are some of the responsibilities to consider that you will need to delineate before you formally partner with another organization.
All right. And one important thing with that too is that you do make a formal MOU and you have that all written up, because you start working together and suddenly it's like, oh, wait, whose volunteer is this? Who's buying that piece of equipment? Said you're going to come how many days a week or a month, kind of all that stuff. It's really nice to have in black and white. And not that you can't change it, just needs change, but it's good to have that. All right. So how do you kind of practically do this? What are the different ways? You've identified what the need is. You've identified who you're going to partner with. You've made that partnership. And now how are you providing your healthcare services? So certainly you could do it in more traditional ways. You can provide care in your clinic setting, maybe tailored to that organization that you're partnering with, whether it's a traditional visit or a telehealth visit. For our partners that are in residential treatment centers or are in kind of safe houses or that type of thing and have a lot of difficulty coming to the clinic, that actually have access to computers or phones, or the organization that's partnering with them has that computer for them, we can do telehealth visits and just be really lenient on things that maybe for someone else we'd really want them to come into the clinic. But when our staff knows, oh, this is someone from Beauty for Ashes, or this is someone at the Micah Respite House, no, we'll just do telehealth for them, and there's an important part of really kind of having your staff understand these are our partners and this is what that partner organization does and what our partnership is with that organization. And even services inside the clinic too. One of the partners that we have is called Lucha Ministries, and they take care of Spanish-speaking immigrants in our community. And so we can partner with them in the sense of making sure that we have Spanish-speaking staff on board when we're scheduling those appointments, or partner with them of some of their staff or volunteers who will come to our clinic to help with translation. Another way that you can partner is for them to come to you. So like I said, with Lucha, that partnership pre-COVID, it hasn't happened as much after COVID, but they would actually have their staff or volunteers come to the clinic and just hang out and provide translation services for us, which was great for us and for their clients. Our partnerships with the food ministries work like this. With the regional food bank, they would park their truck in our parking lot twice a month, and we're a food distribution center. So that's fantastic. And it's not just for our patients. Anyone in the community can come and get food that way. And then they have the Food is Medicine program. Some of you guys might be familiar with it. It's a federal program. So far, it's still getting funding. But, so we have a food pantry in our lobby, and traditionally, like local churches would donate food for our food pantry. But with the Food is Medicine program with the food bank, we have this really nice cabinet and these giant bags full of food for patients to take. And then I mentioned earlier too, the Virginia Community Food Connection, which is kind of like the farmers market, that they can set up in our parking lot as well. So that's people coming to your clinic and providing their services at your location. Of course, kind of this talk is really, how are you going out to that, right? So one way you can do that is with a mobile health clinic, if you happen to have one. When our team was kind of thinking through, right, how are we going to do this? We think we need to move services more out into the community. We thought about doing a mobile health clinic. We had a little committee on the board to kind of figure out what would that look like. And we realized it's really expensive, really hard to maintain. And we decided we can't just do that. Well, fortunately, after our Health Bridge program was in place for a couple years, our health department, who I happen to be friends with, I happen to sit on that steering committee for the community health assessments. They said, Dr. Stinar, we see the great work you're doing in the community. And we found out about this grant that we could use to buy a mobile health clinic, but we have no funding to operate it. If we got a mobile health clinic, would you use it? Yes, I would. Now the ribbon cutting's next month. There it is. A Virginia Department of Health's mobile health clinic for our region that we can use whenever we want and we don't have to pay for or take care of. Exactly. So it's great. So with Micah, yeah, we'll be able to park in a church parking lot that's across the street from them and not be in the clothing closet. Some of the barriers for other ministries, specifically the homeless shelter in town and Mary's Shelter, the ministry that takes care of the pregnant women and their children, those organizations really want to partner with us. Their board of directors is really uncomfortable with us providing healthcare services on their property, but they are more than happy for us to park that baby out in front of their property and provide services from it. If you have access to a mobile health clinic, and like I said, we're in a rural area also, so for us to get out into the country where people just have trouble getting to us, that can be very helpful as well. So that's one way you can get out in the community. And then another way is what we've been primarily doing with Micah Ministries and with Empower House is going to them and providing just our services on site with them. So in this picture here, you see Teresa outside their what they call their Hesed house. It's an old motel, as you can see, and it's kind of used as, I don't know, long-term, short-term, interim housing. They have the respite house for someone that's just coming out of the hospital. But there's a lot of people that just because of their health, they really should not be on the streets, right? Or they really need to recover from something, or they just need a place to stay as they're getting their feet back on the ground again. And so it provides a little more of kind of a interim housing solution. And so I'll go see patients at the respite house or at the Hesed house, or in this other picture, actually in someone's house and doing house visits for those that are getting housing through Micah Ministries. And same thing with we have one of our PAs who goes to Empower House. And, I'm seeing patients in the clothes closet. Empower House was so excited for us to provide services on site with them that they took one of their office spaces and just converted it into a little clinic space for my PA Kirsty there. So she's got a nice couch, she has her exam table and a little scale and, pictures on the wall. The office space she has there is like way better than the office space I have her at the clinic, which made me a little nervous. You can actually go to them and they love it. And it's so huge that she is coming to them because these women that are in safe houses, and we can't park a mobile clinic outside the safe house, right? But it's been a huge blessing for that population. And a lot of that population is an immigrant population also that especially now are afraid to go to the clinic, afraid to kind of go anywhere. And she can provide services to them and she can speak Spanish, which is super helpful also. And so it's just a huge blessing for us to be able to go.
Okay, last audience participation. So turn to your neighbor or the person behind you. How could your clinic provide non-traditional services in collaboration with a community partner? So take just a minute to think about that. Okay, did you have a few minutes or just a chance to throw out an idea or two? How many of you had an idea that you were able to share? Okay, so now we're going to move into some challenges. We want to take a few minutes to share with you some of the things that we've learned through this 3-year-old partnership. Let's talk briefly about some of the challenges that you're going to experience. What if one partner organization wants to be more involved than the other? Recognize that each partner's organizational needs will be different based on their goals, their skills, their staffing, their funding. You'll have to work with an organization where they're at and still work together to meet the overall goal of the partnership. Each might have their own way of doing things. So will you use one organization's way, my way or the highway? We heard that this weekend somewhere else. Or will you combine ideas? Consider that one organization might naturally provide more leadership depending upon those experience, skills, and gifts. Let's face it. Next challenge is that healthcare is challenging in itself. We all know that the healthcare needs of the least of these are great and varied, and while a good partnership will work to overcome challenges, each organization can only do so much. One partner might be less familiar with the nuances of the administration of healthcare or may not have good health literacy. For example, they might not know about HIPAA regulations or about prior authorizations for insurance. For example, I've been an OT in home health for a very long time, so I know a lot about home health regulations and Joint Commission and OASIS, but I don't know anything about running a primary care practice. So Dr. Stinar very patiently has been teaching me. I have a lot to learn still. I'm still learning. So he provides invaluable expertise and leadership to us. The partnership development will likely take some time, and sometimes we don't feel like we have time. This teaching and this learning is back and forth. It can be challenging in itself. How well can your partners support each other? At MICA, we are not the provider, but we are the hosts of the provider that we need to offer primary care in our space. Next, let's consider funding. We've talked a little bit about funding already, but it's recommended that you have your organization build sustainable funding into your long-range funding goals. Be ready to explore other options if funding is cut. For example, can you apply for other grants? Do you want to consider not relying on grants? That brings a huge challenge in itself. How does the current economic climate affect your funding? Can you have a special campaign? How can you expand your donor sources? Do you have someone on your team or in your organization or on your board that can do the big ask? Of note is that sometimes foundations will give grants for collaborative organizations with creative solutions to challenging healthcare needs. That's how we got to where we are. So we recommend that you clearly establish who's responsible for the funding. Is it all up to one person, or is there a finance committee? Lastly, let's look at some of the challenges of staffing and volunteers. You're going to need someone to run the programs that you identify. Who's going to do that? Are there clear roles? MICA hired me to address and expand the healthcare needs of our neighbors. I was a new hire. It was a new position, and it was funded by a grant. But could Dr. Steiner's practice have done this for MICA? And if so, what staffing adjustments might have needed to occur? Does this partnership or new program mean some existing staff member will need to shift some responsibilities? How will that affect the rest of the team or their tasks that they were doing before they added additional tasks? Who's going to pick up the slack and do those things that this other person was already doing? Who belongs to who? We identified that a little bit earlier. Which organization do staff and volunteers belong to, and can they cross over? And we mentioned earlier that Dr. Crawford is working part-time at MICA and part-time at Fredericksburg Christian, so it's a shared volunteer opportunity. And another example was that we recently, not so recently, about a year ago, expanded healthcare services at MICA, and we added another volunteer, a nurse practitioner, who provides some primary care services for us at our respite house, but that's at a different location. She isn't a volunteer or a staff at FCHC like Dr. Crawford is. So there's an increased need for good teamwork and good communication from program to program. You have multiple programs, and making sure that if a neighbor is moving from program to program, that there's good communication, and that can always be a challenge.
We are starting to get a little short on time. Going to kind of breeze through these last couple slides, and then we'll hang out at the end for questions and kind of like the specifics of what we're doing. But we did want to share, or maybe we'll just have time for one story really quick, and certainly we can share others later. But the rewards of collaborating, certainly it can be challenging. There's a lot that goes into it, but the rewards are great. And at the end of the day, you are helping the least of these. You are going out of your way to find the needs that are being unmet. You are partnering with someone, another part of the body of Christ. You're coming together in unity to serve the Lord and advance his kingdom. And that's fantastic, so that in itself is so rewarding. And of course, there's the patients themselves, those who are getting their needs met that otherwise wouldn't. I guess one story I'll share was a patient of ours who was an older gentleman that Micah, I think they just found him wandering on the streets, essentially, and got into their housing program. And at first, what was available was a home on the second floor of an apartment, and he fell down the stairs. And I started seeing him around that time, just kind of see what's going on with him. It looks like there's a little bit of dementia going in, and he hasn't had healthcare services in decades. And, let's start, getting some labs and addressing some things. And what do you know? His A1C was like 10.6, or I think it might have been 11 something. And we started getting him treated. And initially, I started him on insulin. And fortunately, there's a retired nurse on Micah's staff that was able to come and give him an injection every day for a while. And actually, within 6 months, I was able to transition to orals, and we got his A1C down to like in the low sixes. With just orals, which is super awesome, but not just those numbers. We were able to eventually move him out of that second floor housing into first floor housing, which was going to be safer for him, and then transition to the HESED house while I could do some additional evaluations, diagnose him with dementia, do a capacity evaluation. And just recently, a few months ago, we got him into a long-term treatment facility, which is where he just really needed to be, and that was something that never would have happened if we weren't able to go over there and see him, because this was a guy who is never going to seek healthcare services on his own. And if Micah hadn't partnered with us, it would be just another person that they're trying to meet the basic needs of and just kind of keep him out of the ER or keep him alive, but not realize kind of some of the underlying things that were going on from a health perspective that was contributing to his homelessness. So again, we could share so many stories, but we are about out of time. So I'm going to do our conclusion slide here. So we talked about collaborating with other organizations to creatively overcome barriers. And I think that's keys. You have to be creative when you're partnering someone else. You have to be adaptable and see not just what the need is, but how can we meet that in a way that we haven't been? How can we be flexible as we're partnering with someone else that maybe is doing things differently than us? Assessing what your needs are in the community. Like I said, the community health assessment is great. You can also do your own internal process. Identifying who those partners are. And one thing I didn't mention earlier, but when you're identifying that partner, you want to make sure they're a good mission fit with you. You don't want to partner with someone that is going to pull you away from your primary mission. Not that you can't partner with secular organizations. Our food bank is a secular organization. Fortunately, the CEO happens to be a Christian, which is awesome. And Powerhouse is completely secular, but it's been a great partnership. And the Christians that work for Powerhouse are so excited that we're there. And it's been a great witnessing opportunity. But we do need to be careful that, we don't get pulled in another direction. And same with the funding things also, is you don't want to just chase the carrot. You might do that community health assessment and it may say these needs and one of them doesn't align with your mission. Doesn't mean you necessarily go do that thing just so you could get funding for it. So once you've identified who those partners are, you create shared objectives. You figure out exactly what that partnership is going to look like. What are the goals? What are the responsibilities from each organization? And put those in a written MOU. And then, you bear fruit as you come together and work as a team to advance the kingdom. I think we got 1 minute. But we'll take questions. Yes, that is a really, really good question. That was kind of the crux for us as an organization. And a huge part of, as we were figuring out like, hey, this is the direction we feel God calling us to, we said, all right, we need to do a strategic plan. And so we got consultants. Actually, we got John Mills from CCHF, who's here. He was kind of our operational consultant. And then we actually had someone else who's actually one of the elders in our church who happens to be a consultant, a Christian ministry consultant, who helped us with more of the strategic vision. And John helped us, okay, how can we make that work? But part of our plan is actually downsizing our clinic services, which is just kind of the reality. We're trying to hire another provider. So if anyone wants to come to Fredericksburg, but with our capability, we actually 2 years ago stopped seeing new patients and have only been seeing new patients that are direct referrals from all those community partners I showed you early on in the presentation. That's just kind of the place we're at with the bandwidth we have. And we kind of have a plan of slowly losing patients through attrition, just because I just don't have the heart to say, sorry, private insured patients, we're just not going to see you anymore, even though you've been with us for 20 years. And there's the reality that a patient might be uninsured and then they get on Medicaid and they get a job that gives them private insurance and they lose that job and now they're back uninsured or on Medicaid. And so it's kind of hard as a family physician. Like, I don't want to kick someone out of my practice who I've been seeing for 10 years that's still in poverty, regardless of their insurance status. But to answer your question, we are intentionally downsizing our in-clinic services so we can do more services outside, which for funding is also challenging. because we're losing some of that revenue, and it puts more strain on us for grants and fundraising efforts. As you're sitting behind our development director, who I just hired last year, because that was part of the strategic plan too. So, how are we going to do this? I can't do it at all as CEO/physician. So we need help. So yes, we did have to hire people also, trying to hire providers, but not just providers. I also hired a director of operations too, which I haven't had before, really probably should have had 10 years ago. But because it was like, we can't do this without additional administrative support. Our relationship with the health department for most of our 20-year existence was essentially we would help them with like TB screenings and STI screenings and kind of just stuff like that. When I joined the practice in 2013, so I have a little stronger of a women's health background than our founding physician, who is an IM guy, IM peds. And so they didn't really hardly do anything. Some of the nurse practitioners at that time would do pap smears occasionally, but we really didn't do much. And I do like colposcopies and IUDs and just kind of everything, right? Used to do prenatal care. And so when I started doing when I said, hey, I can do colpos, there is no one in our region that would do colpos for uninsured patients. And again, before Medicaid expansion. So literally every health department in like all around us in our region, there was like 5 different health departments that when they had an abnormal pap smear, they would refer them to me, because otherwise people would have to drive an hour, University of Virginia or VCU, one of the big teaching universities. So that really helped. So they saw that I was doing that. And then I got asked to participate in the community health assessment process 6 years ago or whatever, and was really involved, was vocal. Was a very active participant, and they appreciated that. And so I think that helped a lot. And I will say this, I think one thing that helps too is, even though we're a Christian organization, in all of this, I'm not shoving anything down anyone's throat. I'm not making a scene. I'm not making controversial statements. I'm just showing that I love people and want to help. And I think that's been helpful also. Yeah, because those leaders in the health department that I have good relationships with, they're not Christians. It helps, like the guy at the food bank, him being a Christian, that's great. That's so awesome. Our local Mental Health of America chapter, she's a Christian. That's super helpful. But yeah, at the health department, it's just formed that way. Other questions? Yeah, I think that's challenging. With the cap, at the end of the day, you have a capacity. You can't take care of everyone, and so you can only do what you can do. And that kind of answers the first part also, is in all this, you have to really know what is your mission, what is your organization's strategic plan, what is the vision, and does that program align with it? And if it's something that you guys say, look, this specific program, this organization we're partnering with, this is like who we are, this is key to what we're doing, then you're going to realign your resources to keep that going. Maybe something else kind of gets pared down. So like the question earlier for us, it was, it is great that we are taking care of patients who have private insurance and Medicare. At the end of the day, our mission statement is that we exist to take care of the poor and marginalized in our community. So if something has to be cut, it's got to be services that we're doing that are not to the poor and marginalized. So there's that shift. In terms of grants, I will say this, not all grants are state and federal grants. Our organization doesn't get any state and federal grants. They're all private foundations. So that would be something to think of and to see, are there some local foundations, family foundations that support Christian ministries, kind of think in that way, or shift to like fundraising activities. And people love to give to organizations that collaborate. Anyone who writes grants will see that is that there's a lot of grants that, won't even think of you unless you are in some way partnering with someone else. So there's not redundancy. And donors also, when you can go to a donor and say, hey, you've probably heard of Micah Ministries, and I know you actually donate to them. Did you know we're working together and we're doing this? And you tell that story and people are like, oh, that is fantastic. That is great. Yes, I want to support that.
Thank you all so much.